of the sagittal section through the body. And this shows this peritoneal, this serosa covering of basically the organs as they've grown into the peritoneal cavity and become covered with this peritoneum. Now, since these are organs, just like in the thorax when we were talking about pleura, and we had pleura that was associated with different wall areas, for example, the mediastinal pleura, the diaphragmatic pleura, the costal pleura, and so forth, that was associated with the parietal wall. In the peritoneal cavity, any peritoneum that is on a wall is parietal peritoneum, okay? Not a lot of separation, okay, in relationship to nomenclature. However, the organs themselves become covered with peritoneum as they grow into this space, And the space that they are given is all they get. So to occupy this space, since a lot of them are very large tubular organs, they have to literally coil on themselves to find a place in this space to stay, okay? You know, it's kind of like going to a large event where there are a lot of people packed in. There's a lot of organs packed into this space, okay? So they have to find a comfortable place to go. So, for example, up here, here's the liver, or a sagittal section through the liver. And as the liver grows into this abdominal region, it becomes covered with pleura. Peritoneum, and this peritoneum is actually, to a certain extent, reflecting off of the wall, both anteriorly but also posteriorly. So in many ways, it is going to help to form this structure here we call the greater omentum, and I'll draw this in a minute, and also have an interconnection with a peritoneal ligament interconnecting the stomach. Here, M is for, the M for the stomach means mesogastrum. That's the anatomical term for stomach, is mesogastrum. And so between the liver and the stomach is a peritoneal ligament that is referred to as the lesser omentum, okay? Not as big as this great apron-like structure, the greater omentum, not really that much fatty infiltrated, but it is still there, associated with things like gastrohepatic ligament, hepatoduodenal ligament, that are forming this relationship. Now, the reason why it is called lesser is not because it's small, but because it is a relationship between the liver and the lesser curvature of the stomach. We'll see this when we look at the organs, that the stomach is kind of a very large J-shaped bag for the most part. So the lesser curvature of the stomach gives a point of attachment for this lesser omentum. And then the stomach kind of gets covered by some of these ligaments, like the gastrohepatic ligament, along with a peritoneal reflection off of the back side of the liver. So this omental sac here, this lesser sac, or omental bursa, gets formed by this bilayer, by this peritoneal bilayer, that is creating this space inside of peritoneum reflecting off the surface of the liver, as well as peritoneum reflecting off the surface of the stomach, and this structure here, the transverse colon. Okay, so we see this peritoneum coming to play to form this sac. Now, once again, a sac-like structure anatomically is many times referred to as being a bursa. Not necessarily like a bursa sac that we see in a joint where this is part of its synovial wrappings, but basically just a sac. Now, everything outside of this sac, out here, for example, is in the peritoneal cavity itself. The greater sac is the peritoneal cavity itself. And then we'll see once again that there's a space deep to this lesser omentum, where you can actually, in the cadaver, I'll actually show you this. You can put your finger under this sac, under this omentum, this lesser omentum, and enter into the lesser sac. Now, as I mentioned to you at the end, which was kind of a little bit of a rush, that there are things that can get back here into this into this lesser sac area, into this area behind the omentum, or within the greater omentum itself, in this area we refer to as the omental bursa. And that's not a good thing, because it's kind of tucked into a space that's not high in lymphocytic organisms, or lymphocytic cell populations, and so forth. So something that gets in there is really quite dangerous. Years ago, we did not have all the antibiotics that we have today to treat any types of abdominal infections. As a matter of fact, even in today's medicine, we don't have a lot of antibiotics that do well in terms of treating abdominal infective disease. And abdominal infective disease could spread very rapidly, because this is basically a lining that is secreting. It's a secretory lining, a serosa. And so if an infective product gets in it, it flows through this chamber just like the peritoneal fluid flows, okay? And that's really, we were talking a little bit about appendicitis. That's why appendicitis is so dangerous, because if that appendix ruptures, all of that bacteria, including the ones that were already there, these symbiotic bacteria, but other buildup of other bacteria within the confines of the appendix, breaks open into the abdominal cavity. This is a very difficult abdominal infection to treat, would be a burst appendix, and actually very serious in terms of the possibility of being life-threatening. So this sac could be involved with an infection as well. So early anatomists had to really know where these spaces were, because how they helped the body out wasn't so much in relationship to things like antibiotics, but with putting drainage tubes in certain areas to get this pus, this exudate, out of there as fast as they could, to give the body a chance to fight these infections without having anything else other than trying to remove as much bacteria in these exudative type spaces. Okay. So over here we have this double-walled sac. This is the this is the greater omentum. It's a double-walled peritoneal sac coming off the liver, the stomach, and the transverse colon. And the inside of it is called a small sac, or the lesser sac, or the omental bursa. Now, the small intestines, here J for jejunum, I for ileum. We see here D for duodenum. The duodenum is kind of interesting in relationship to the peritoneal cavity, as is the pancreas. Okay. So this is a sagittal cut. This is a sagittal cut, like taking a large bandsaw and going down the center of the cadaver of the organism. Hopefully you don't do this on any of your friends. But we see here P for pancreas and D for duodenum in the midline, in this midline portion of the sagittal plane. Okay. Now, if you notice, they're not covered with peritoneum. They are actually behind the peritoneum. So, as organs that are behind the peritoneal cavity or not within the peritoneal cavity, they are said to be theoretically behind the peritoneal cavity, or what we call retro, or behind peritoneum. So the pancreas and the duodenum, the head of the pancreas is tucked in through the duodenum as it wraps from the pyloric sphincter around to form its little 1 foot extension to join the jejunum. At this point, both the duodenum and the pancreas are retroperitoneal. However, as they extend out towards the left lateral abdominal wall, they become covered with peritoneum. So the tail of the pancreas, or the terminal portion of the duodenum, are covered with peritoneum and are within the duodenum, are within the peritoneal cavity. The jejunum is definitely there. The ileum, these are the longest sections of the small intestine. As they grow into here, they are growing basically hooked on to the posterior abdominal wall. If for no other reason, they are being hooked on by the vascular bed coming from the aorta that is supplying these organs. We'll talk a little bit about that today, this afternoon. So those organs are coming off from the aorta, which is at the posterior abdominal wall. Remember, we saw that last semester when we were looking at the aorta and the vena cava in the posterior abdomen, along with organs like the kidneys. So they come off the wall, they come off, and these vessels are protected by huge amounts of fat and the peritoneum covering the organs. So this is what we refer to as a mesentery proper, or the dorsal mesentery. That is this fatty infiltrated peritoneum that is attaching the jejunum and the ileum, and in some cases portions of the large intestine here, the sigmoid colon, to the posterior abdominal wall. That's what a mesentery is literally defined as. It's an extension, a peritoneal extension, fatty infiltrated peritoneal extension of coming from the posterior wall. And once again, we are bipeds, so everything with us, we're supporting it from dropping down into our pelvis. In a quadruped, if you would take a fluororadiograph, a fluoroscopic image, you would see their organs are literally hanging down off of the posterior wall, but not touching the inside of their anterior abdomen. Okay, they would just be hanging there. But they are primarily live a horizontal life. We pretty much live a vertical life. Other organs in here that we see, here's a portion of the end of the colon back here, and this is pretty much a portion of what we refer to as the rectum. The rectum is essentially, for the most part, retroperitoneal, is along with the sigmoid colon, and so there is peritoneum on the front side of it that's just kind of laying against it, but it is not wrapped in peritoneum, so it's considered to be retroperitoneal. Then, this is a diagram of a female sagittal split. Okay, here's the pubic symphysis here. Sitting behind the pubic symphysis is the urinary bladder. Sitting behind the urinary bladder is the uterus in this female. Now, the uterus, for the most part, is in the peritoneal cavity. However, the uterine cervix is not. The uterine cervix, as it joins the vaginal opening here, is retroperitoneal, but the body and the dilation, the fundus of the uterus, are within the peritoneal cavity. Okay. The urinary bladder is not. It is covered on its outside by peritoneum from above, but it is not wrapped in peritoneum. So the urinary bladder is also considered to be an organ that is retroperitoneal. Okay, so those are these entities associated with the peritoneal cavity. Okay, so here is kind of a frontal section through the omentum. This is a frontal section through the omentum, and what we see here is this opening behind the liver, underneath the pyloric sphincter portion of the stomach, and underneath really the liver and the duodenum back here, and that is the epiploic foramen, and that goes into this sac that's inside of the greater omentum. This is the lesser sac. All of this here, we cut out the front of the lesser sac, but we can see that this is a bilayer of peritoneum that helps to form this fatty infiltrated apron. And then behind this apron are the jejunum and the ileum. Okay. If we look at it in a horizontal section, we can see something similar. And here we show the relationship between the left and right side. Now this is a transverse section, okay, a horizontal section. And this is at the level of T12L1. So between the last thoracic vertebral body and the first thoracic lumbar vertebrae body, we've got these structures. So over here on the left, as we're looking down on this, here's the stomach, okay? Here is the spleen over here. There is a ligament, a peritoneal ligament between the spleen and the stomach called the gastrosplenic or gastroleonic. Leonic is a term that's also used to describe spleen, okay? Back here, we have a cut through the top of the left kidney. Over here, we have a cut through the kidney a little bit farther down, okay, in relationship to this, okay? Why is that? Why do you think it's not directly through the middle of the right kidney, showing the region we call the pelvis or the hymus? What's the difference on each side? What's the position of the kidney on the left versus the right?
The liver pushes the left.
The liver pushes the right kidney further caudally towards inferiorly, okay? But there's nothing that does that. The stomach isn't a dense enough organ to do that on the left side. So the kidney's a little bit higher on the left side than over here on the right side. Okay, now here is the vertebral column. So what do we have sitting on the vertebral column, if you remember? We have the abdominal aorta, and then over here we have the inferior vena cava, which is going to be actually running under the liver and receive the liver's vascular drainage as it passes under the diaphragm and back into the right atrium of the heart. Here is the pancreas kind of laying underneath this peritoneal space here, which is part of the omental space, or part of what we refer to as the lesser sac. Now this structure right here, okay, this is actually the pancreas kind of uncovered, or uncovered. So it's behind the peritoneum, it's retroperitoneal, okay? But as we move out, the pancreas gets surrounded by peritoneum as we move to the left. Okay, and then here with the liver is a little bit of the, kind of the bottom of the gallbladder, okay, this bile storage device. So just another view, then all of the back musculature, these rector spinae muscles, back behind the vertebral column, over here. So as these organs are attached to one another, they are attached by peritoneum. But once again, as I alluded to this morning, a ligament is something that attaches bone to bone or organ to organ, organ to organ. In the thorax, we had this pulmonary ligament, which was attaching the hilus area of the lungs to the mediastinal pleura. Okay, so that was actually a pleural ligament. Here we have a wide variety of ligaments associated with interconnections between structures. Even in the abdominal wall, the round ligament of the liver is an extension of what was left behind as a vestige of fetal development, this umbilical vein, which when it was, the cord was cut, is no longer having any blood, so it atrophies over the course of time, and it becomes a dense, really a more dense peritoneal wrapped connective tissue that is attaching the underside of the umbilicus to the liver, okay? We'll see where that is actually as we move into the organ systems. But we've got gastrohepatic ligament, the hepatoduodenal ligament, which form this lesser omentum. We've got gastrosplenic ligaments. These are all peritoneal reflections. We've got gastrocolic ligament, which attaches the stomach to the colon, which is helping to support this greater omentum as it is hanging down over the small intestines. We've got gastrophrenic. We've got ligaments between the diaphragm and the stomach. I'll go back up in a minute because that's interesting. We'll see it again in some illustrations for today's lecture. But we have an interesting ligament. It's almost like there's some muscle in it. It's a musculofibrous, it's fibrous, and that it forms from tissues around the celiac trunk, this first arterial branch of the aorta in the abdomen, and a diaphragm extension down to the lumbar vertebrae called a crus, and this is continuous with the mesentery associated close to the duodenum, the caloric area of the stomach, It is a suspensory ligament. It's helping to support these in relationship to interconnecting the diaphragm. Sometimes in things like duodenal ulcers, it becomes inflamed and it starts to go into contracture. And it feels as though you've got this tightness in the area of the diaphragm. And so this was described by Treitz. So this is called the ligament of Treitz, or the musculofibrous band of Treitz. Ligament of teres from the liver and the umbilicus, coronary ligaments, triangular ligaments. These are all associated with the liver. We'll be talking about those. But I'm going to go back to that peritoneal slide and show you something in relationship to as these ligaments are coming to the liver. So here is the diaphragm. And then here is this pleura interconnecting the liver to the diaphragm here and here. But if you notice here, there's no peritoneum. There's no peritoneum, okay, covering that portion of the liver. So the liver is bare of peritoneum at that point. Is that some kind of an oddball thing? No, the liver's a big organ growing into this peritoneal bag, this large peritoneal cavity, and as it stretches the peritoneum, it really, as it is tightly bound to the diaphragm where the inferior vena cava is coming in through the diaphragm and into the heart, it doesn't get covered. So it's bare. It's bare peritoneum. That's the bare area of the liver. And there's some other ligaments that help do this, and they're called coronary ligaments, and we'll look at that as we look at the organs themselves. Okay, all right, so let's move on to the organ systems that we see in this area. The abdominal pelvic organs. Now remember, this whole cavity as its whole is called the abdominal pelvic cavity. The abdominal cavity proper ends in what we call the pelvic rim. This region between the top of the first sacral vertebrae that comes around to meet the ilium and the pubis and the ischium. It creates an artificial plane, and at that point, below that plane is pelvis, but above it is abdominal cavity, not pelvis. But the whole cavity itself with everything is abdominal pelvic. From the same standpoint, peritoneum lines the entire cavity, including areas of the pelvis, okay? In particular, and we saw in the female, it comes down to surround the upper 2/3 of the uterus. So, the peritoneal cavity is within the abdominal pelvic cavity, okay? It is basically a peritoneal bag. So if we look at this here, I don't know if I do that. I hit the screen instead of my computer. So here we see kind of an overview of the organs of the abdominal cavity, and we see up here, here's the costal arch, and wherever the costal arch is, on the inside of this is diaphragm, okay? This isn't free from diaphragm. This is covered here with diaphragm, and it's coming over the top of the liver and the stomach and the spleen up here that we don't see. And here's the ascending colon, the transverse colon. We can't see the descending colon. But here in the middle, we see this large, small intestinal tube that we refer to its portions as the jejunum and the ileum. All right, so let's talk about this large organ here, the liver first. As we look at the liver, The liver, as it grows, actually primarily, it grows from two lobes, a large right lobe and a left lobe, that during late fetal life, they merge together to form an entire liver. And that has to do with some of the vascular supply associated with the liver itself. Now, the liver is an organ of the peritoneal cavity. It is completely covered with peritoneum, so this is visceral peritoneum on the surface. Here, this peritoneal reflection would come to the anterior abdominal wall. This is called the falciform ligament. At the base or underside of the falciform ligament is this dense, very dense ligament that's coming from the umbilicus. This is the round ligament of the liver. Okay. So here we have visceral peritoneum. Okay. Here we have a peritoneal ligament coming from the anterior wall. This is called the falciform. It has to do with how it's shaped. Here, down here, we have this remnant of the umbilical vein from embryonic life, or fetal life. This is the round ligament, or talk about this lig here, or ligamentum. Teres. Okay, so these are ligaments that are associated with the surface. Now, here once again is the diaphragm up here. And then interconnecting the diaphragm and the liver are actually 4 peritoneal ligaments. Two of them we can see here on the outside. Here and here. And these are called the left and right anterior coronary ligaments. Once again, a peritoneal ligament. And then at its lateral corner here, it is going to join now, this is the back of the liver, and here is the inferior vena cava. Here are the anterior coronary ligaments here. Here's the anterior coronary here, and here's the anterior coronary. This is the right, this is the left. Okay. And here is the posterior coronary. Comes up here. This isn't quite as thick, but it comes over here. So that anterior coronary comes out to the side and it joins the posterior coronary. And so these are posterior coronaries. Bless you. Okay, we're down here. And where the anterior and posterior coronary ligaments join, out here, these are called triangular ligaments. So, what we see here is we see an area pretty much over to the right, but a little bit at the left, that is not covered with peritoneum. It lies between the anterior and posterior coronary ligaments, or it lies medial to the triangular ligaments out here that are joining the anterior coronary and the posterior coronary. That's the bare area. That's the bare area up against the diaphragm that's not covered with peritoneum. Okay. Now, underside here, underneath the liver, there is also a attachment here. This is the round ligament. This is the underside of the liver now. Here is the gallbladder. Why is it green? Tim talked to you yet about bile? Okay, because one of the bile pigments is called biliverdin, green bile. Okay. So this is the gallbladder. What's bile a byproduct of? Okay, of blood cell breakdown, blood cell wall breakdown. Okay, blood cell wall breakdown. Okay, it's high in triglycerides actually. Okay, or lipids as well. Okay, what does it do? Emulsifies fat. Okay, emulsifies fat. Okay. Breaks fat down. So what product do we use on a daily basis that emulsifies grease? Soap. Okay, so this is basically physiologic soap. Okay. And this was released from the gallbladder into the duodenum. Okay. So here is the vena cava, the IVC, and over here is the remnant of another embryonic ligament or an embryonic structure, and this is a remnant of the ductus venosus that interconnected the umbilical vein to the vena cava. Okay, so now it's a remnant, and it's called the ligamentum venosum. And as we use these extensions here, now the liver has these two large lobes that we call over here, let's see, right lobe and left lobe. But now we've got two smaller lobes. This lobe at the inferior border next to the gallbladder, which is kind of shaped like a square. So we call that the quadrate lobe of the liver. And up here between the vena cava and the ductus venosus, we call this the caudate lobe, because it's near the tail end of the liver. Okay. So now this is the external surfaces of the liver showing the different lobes, the four lobes, the two very large lobes and the two smaller lobes, and what causes the separation that causes these lobes, and also the bare area of the liver, because it is a non-peritoneal covered area between the tail of the liver and the diaphragm. Okay. So here is a vascular picture of the liver. Over here, and this is showing a lot of things. Okay, here is that quadrate lobe. Here is the remnant of the umbilical vein. Now the ligament teres of the liver, or around ligament of the liver. Here's the gallbladder, here's the quadrate lobe under here. Up here is the tail of the liver. So here is this ligamentum venosum and the inferior vena cava subdividing this other small lobe into, this is the caudate lobe, right here. So caudate towards the tail liver, quadrate down here towards the inferior aspect of the liver. Now, got a lot of vasculature that goes through the liver. We basically have three systems of vessels. One of the systems of vessels we'll talk about are venous vessels that are coming in via this vein here called the portal vein. Okay, the portal vein, which is taking blood from all other intestinal organs, including the spleen, okay, and taking that blood to the liver. Why? Why do we need to do that? Why do we need to do that? What's the role of the liver? It's a huge multi-metabolic organ, okay, that's going to have decisions to make in regards to whether we free up things like carbohydrates, lipids, and proteins into circulation, or we package them and store them, such as protein and fat and glycogen. Okay, whether we do that, either the body needs them right away, or we got enough going on right now, we don't need it either. Okay, and this is coming in from all organs, in particular your large tubular organs, because this is where the substances are being further broken down to metabolic units that we can use as metabolic substrates for our metabolism of all our cells. Okay? So that's the portal vein. Now, then we've got arteries that come in to supply the liver. And these arteries are branches of the aorta, just like in other abdominal organs, we have branches of the aorta, like the celiac trunk, superior mesenteric artery, and so forth, that are supplying the abdominal organs. Okay, so these are aortic branches. This is the hepatic artery proper, actually, that many times it's defined as. And then we have a second set of veins, which is taking things from the liver and creating flow of these entities into the circulation of the organism through this vessel, which is going directly back to the heart. This is the inferior vena cava. Now, in the abdominal cavity, the last organ to drain into the inferior vena cava is the liver. These are hepatic veins draining into the inferior vena cava. This is the inferior vena cava actually coming against the posterior abdominal wall, draining units such as the posterior abdominal wall, the lower extremity, okay, the kidneys, the adrenals. That is all draining back in here, okay? Now, these spaces between these vascular bed entities are referred to as sinusoids, spaces between the vascular entities as they come together. So this is kind of a cutaway view. There's actually, if you get the book McMinn, which I advise, that it's an excellent book for head and neck lab as well as any other lab. McMinn in there has a latex cast of a liver. So he takes what we see here and he injected latex into these vascular structures, and we see this huge network of vessels inside the liver as they essentially cut most of the liver away. Okay, so associated with the liver is this structure kind of tucked in to the right lobe. And this is a bile storage sac. Does it produce bile? No, it's just a bile storage sac. Where does the bile come from? The liver, okay. So here are ducts from the liver, left and right, hepatic or cystic duct, okay? and they are going to release bile into this long duct that's gonna come down here into the duodenum, to the descending portion of the duodenum right here, okay? And so, do we need to just throw it into the gallbladder? I mean, what if we've got a high amount of lipoprotein to break down? We are heavy into meat. We are heavy into meat, okay? Meat is muscle. Muscle has membranes that are lipoprotein, okay? That's the problem with meat. It's not so much the fat. The extra fat doesn't help in, fatty meat, but the problem is that high quantities of meat have a lot of lipoprotein that we have to help break down by releasing bile to emulsify some of this fat entering into the digestive tract. Now, at normal levels, the gallbladder doesn't really need to store anything. However, if we go between meals and we have one meal that's very high in lipoprotein, and then for a couple meals we have that we go to the other extreme. We go to the vegetarian or vegan extreme, okay? Well, we don't need the bile. So this opening here is going to close because we're not really going to get any high need for bile into the digestive tract for emulsification of fat. So it's going to back up into the gallbladder through this duct. This is the cystic duct. These are the common hepatic ducts. Okay, over here. It's going to back up into the gallbladder. Now, what is bile? What kind of a solution is bile? Well, certainly it's aqueous, it's a liquid. But what more specifically? What kind of solution is it? What is bile? It's a salt. It's a salt solution. Okay. You all took chemistry, right? What happens if you concentrate salt solution? What happens to the salt? Precipitates out of solution, right? Okay? And we're walking around with all of these salt crystals in here that got no place to go because you decided that after living this, sinful meat diet, you were now going to become a vegetarian, okay, or a vegan, okay? And so the bile is just sitting in that gallbladder, and the bile salts are precipitating out of solution. And as you move around, you kind of jog these internal organs, and these salts form crystals, and then the crystals form larger crystals, and then the larger crystals form little balls, okay, called gallstones. And some of these gallstones are so large that all of a sudden if we decide to say, I really wasn't intrigued with the vegan life or the vegetarian life, I'm going back to meat. Take me to McDonald's, Wendy's, Burger King, somewhere, Rally's, wherever. I'm going back, okay? I'm going to get off, I'm going to get off on the wagon again, okay? Get off the wagon. So what we have happening here is now these gallstones are so large, and now the body is saying, okay, I need a lot more bile because we've got to emulsify all of this lipoprotein. So if you've got a large stone in there that's bigger in diameter than the bile duct, than the cystic duct, when the gallbladder, which is basically a smooth muscle bag now, contracts, it can't move the bile, can't pass the gallstone. And gallstones are salt. Okay, so they scratch the inside of the gallbladder. And the gallbladder elicits a painful response in relationship to situations associated with chronic contraction of the gallbladder itself. Yes?
How long does it take to form the stone? Because I'm a vegetarian and now I'm concerned that I'm going to form bladder stone.
As long as you don't go crazy, okay? You're safe. I mean, have you essentially been this most of your adult life?
Yeah.
I doubt if you have any problems. Because if you have any gallstones, they're probably small. Okay?
But that's a good thing to have.
Yes,
vegan.
yes.
Because everybody keeps on saying that we should shift over to vegan diet. And have you seen the Netflix movie Forks Over Knives?
No, I haven't seen that one.
It's all talking about how eating plant-based diet is actually good for the liver and heart. So it's just interesting to see that it's not good for them.
Although, you know, cellulose in some ways is similar, has some kind of, the membranes are somewhat similar to meat, but not quite the same, okay? So the liver says I'm not gonna produce as much bile, okay? It doesn't mean that the liver is going to stop turning over cells, or the spleen, where the cells are being broken down after around 120 days, are not going to produce bile, but not in as great a quantity of storage in the gallbladder as they were if we were on a meat diet. Okay? Because things like cholecystokinin and things like that cause really the buildup of bile. Okay? And that is signaled by the small intestine primarily. Okay? So, no, you're going to be okay. You're going to be okay. Unless at some point in your life you say, the heck with this vegan life. You know, I'm going back to a hamburger. You know, I'm going back to, what was the movie with the guy in the McDonald's? Yeah, Super Size Me. And you would think that we learn from that. But burgers are bigger than I've ever seen. I mean, now now it's not just one patty, it's two patties, it's three patties. Let's throw some bacon on there. You know, let's get some cheese on there. I mean, you know. So what have we learned? I mean, my brother-in-law and his family actually went totally vegan, but he wasn't totally vegan his whole life. And so they've had a lot of significant weight loss in relationship to that. And they don't really miss it. And to be honest with you, I don't mind high plant-based meals. You know, myself, I do a lot of cooking with beans and things like that, or quinoa, or things like that. But every once in a while, I'll throw a hamburger, you know, or flank steak or something. Okay, you know, a little breakfast abdominis never hurt anything. All right, so the gallbladder has the cystic duct that interconnects with the common bile duct, okay? That's what this is, the common bile duct. Okay, so the common bile duct interconnects with the duodenum over here, okay? So this is common bile. But there's another duct leaving the pancreas that comes in here simultaneously, and that is this duct here, and this is the pancreatic duct. Okay, so this is one of the most confusing things for students in anatomy, okay? When these two come into the outside of the duodenum, they form a kind of triangular tissue lump, okay? And this looked to the scientists, they said it's ampular shaped. Have you ever seen a medication ampulla where it's a glass vial where the top of the vial is kind of tapered as it comes to the container? Okay, so they call that an ampulla, okay, of medication. And you break the top off, you put it in whatever, you suck it up in a syringe, inject it, or whatever. So, you know, you still see some of this in medication delivery, all right? But it forms an ampulla-shaped structure where these two ducts are entering through the duodenal wall. And so they say that this area specifically on the outside of the duodenum is called the duodenal ampulla, and it was described by an anatomist named Botter. So an older name for it is the ampulla of Botter, okay, or the duodenal ampulla, not papilla, okay? On the inside here, we have an opening that, around that opening is actually a raised ridge, and this is a papilla, you know, like periodontal papilla, the interproximal extensions of the attached gingiva, okay? This is called the duodenal papilla, and inside that papilla is a small amount of smooth muscle. So this papilla is actually forming a sphincter, a valve that we can close, called the duodenal sphincter. But the papilla was described by another anatomist, and his name was Odie, not Obi-Wan Kenobi. This has nothing to do with Star Wars, but Odie, okay? So this is called the sphincter of Odie, okay? The duodenal ampulla or ampulla vater, the duodenal papilla internally, or the sphincter of Odie. Okay? So both pancreatic substances and bile come in at the same time. That kind of makes sense, doesn't it? I mean, because why wait in relationship? Usually, I mean, even in a vegan diet, there's carbohydrate, okay? And maybe sometimes that's a problem. Some people say, well, I can't get fat in a vegan diet. I said, oh yes, you can. But you have to be careful, also, a quantitative aspect of eating is probably more important than, in many ways, the qualitative aspect sometimes. All right, so we have the release of bile from the common bile duct from the liver into this area, if necessary, this fatty emulsifier. And we have pancreatic enzymes. What are pancreatic enzymes? Name them. Huh? Glucagon is not an enzyme, it's a hormone. Okay? Insulin is a hormone. And they are not released into the duodenum. Where are they released?
Bloodstream.
The bloodstream. They're endocrine. Okay? I thought you guys had. No, that's the second years. Okay. All right, you haven't had endo repro. So I'll forgive you. All right, so the pancreatic duct is releasing, in particular in relationship to carbohydrate metabolism, like in relationship to glucagon, it is releasing amylases, pancreatic amylases and things like that for the further digestion of carbohydrates. Okay. Also, coming in here, interestingly enough, is another entity. Do you know what that entity is? Bicarbonate. Why? Where was this stuff before it came into the duodenum? What was the stomach doing? It was just, loading down there and said, okay, eat this, we're going to dissolve it. We're not just going to break it down, we're going to dissolve it. So we're going to release from the gastrointestinal wall, the gastro wall, we're going to release acids, hydrochloric acid, to help in the breakdown. But then we've got to do something with this acid. We can't have a high acid level chronically, otherwise that's going to cause internal tissue damage to these tubular organs. Okay, so we release bicarbonate in there as well to deal with the high acidity. Okay, so then we come over here to the stomach. We'll do the stomach and then we'll take a break. Okay, so the stomach is said to be a large J-shaped bag. Here we've cut through it. There are a variety of different regions. The diaphragm is up here. This structure is passing through the diaphragm to the stomach. This is the esophageal tube. So this is the gastroesophageal junction here. They call this notch between the esophagus as it enters the stomach and this area called the dilated portion or fundus, or room, so to speak. We call this the cardiac notch. And this junction with the stomach and the esophagus is called the gastroesophageal junction. Any of you have GERD, gastroesophageal reflux disease? Do you have any family members that have gastroesophageal reflux disease? Okay. So what's happening there is the stomach is getting irritated enough at the gastroesophageal junction to cause backflow of these acids into the gastroesophageal junction and into the lower esophagus. And that's usually painful. And we've got the diaphragm right there. So sometimes this too can be mistaken for some kind of intrathoracic type of problem, like a heart attack, myocardial infarction. Here we have the body of the stomach. The internal aspect of the body of the stomach you would see in a unfilled stomach, you would see all these folds. What are these folds called? Rugae, ridges. Any place else in the body you see rugae? Oh, come on. Where do you see rugae? What about in the palate? Behind the central and lateral and incisors and the canine, those ridges. Those are also called rugae. Okay? Okay. Okay, so they're folds. Okay, they're basically folds in the stomach. The stomach is a relatively normal sized bag, but you can really fill it quite a bit. You know, I don't know if you've ever tried this, but individuals do try this on a regular basis. You see how much they can get into the stomach. And that creates a long life problem, because you can wind up stretching this so that the stomach basically is overly stretched and does not recoil into its normal size. It just stays stretched. And this is where you have these so-called bariatric procedures, where they go in there and they put a big rubber band around the stomach. Why, I don't know. But they put this big rubber band around the stomach to try and help the stomach contract on the substances that are coming into it from the esophagus. Okay. All right, we come down here and we've got a tapering. This is basically the vestibule. This is the pyloric antrum. This is the space that separates the body from this region here, the duodenum, okay? And there is another sphincter, another valve here, that is called the pyloric sphincter, or the pylorus itself, which is a circular smooth muscle sphincter that can contract and reduce the flow of substance from the stomach into the duodenum, the small intestine. So that's what we see here. Now, gastroduodenal ulcers are typically happening in this area. So, for example, what causes this? Well, a lot of irritation from gastric acid causes it, but also sometimes excessive contraction of this pyloric region because of, you know, some type of abnormal peristaltic entity associated with this region. Or you can get spasms associated with smooth muscle as you overly stretch it. And sometimes this causes referred blade pain. Okay, why don't you take a break? What's the stomach for? What is it? It's a reservoir for food. We take this food in and we continue the digestive process by trying to break it down with this hydrochloric acid. Okay, mix it up. That's what these folds, as they cause the stomach to stretch, they will contract. Okay, stomach's a smooth muscle bag. Okay, just like most organs in the gastrointestinal system, they are smooth muscle walled entities. Remember, when you stretch a muscle, it wants to contract, whether it happens to be vascular smooth muscle, whether it happens to be skeletal muscle, whether it happens to be gastrointestinal smooth muscle. So as you fill these bags, they want to push back on that quantity of substance that's causing them to stretch. The rugae allows the stomach to expand. Okay, they are nothing special other than folds of smooth muscle in the walls of in the stomach itself. So they can be flattened out as the stomach fills. All right, so let's move right along. Okay, so here's the relationship of the duodenum to the pancreas, okay? Here is the gastroduodenal junction. This is at the pylorus. And as the duodenum comes, it kind of forms a 12-inch curve, okay? And inside that 12-inch curve, here, remember, here's the vena cava, this is the abdominal aorta. So this is the most sagittal area of this region, okay? So remember, we cut that organism to show the relationship of peritoneum to organs, and we saw that initially the duodenum and the pancreas in the sagittal line and sagittal plane are not in the peritoneal cavity, they're behind it, the retroperitoneal. So this area here where the duodenum is wrapping around this structure, this is the head of the pancreas, this is the tail of the pancreas going out to the left. Okay, here's some of its vascular supply. Here's the pancreatic ducts coming in here. Okay? And going into this area, really between this upper portion up here, which is the first, sometimes referred to just the first portion of the duodenum, kind of has somewhat of a subtle horizontal position, and then the second portion is a descending portion, and then the third portion is another horizontal, lower horizontal portion, and then there is an ascending portion. This area in here is where the duodenum actually gets interconnected to this ligament of Treitz, which comes up as high as the diaphragm. Okay. So right here, the head of the pancreas is tucked into the duodenum. This area right here is retroperitoneal. As the duodenum comes a little farther lateral to the left, and the pancreas tail comes out to the left, they become enveloped in peritoneum. So now they're not behind the peritoneum, they are surrounded by peritoneum and part of peritoneal organs. But the head of the pancreas and the beginning of the duodenum, the first, second, third portion surrounding the head of the pancreas are retroperitoneal. They're not in the peritoneal cavity, they're behind it. So we talked about the pancreas a little bit. It does a lot of things. It has basically a endocrine function in relationship to the release of two important hormones, insulin, which stimulates the absorption of organs, the absorption of glucose into organs, and glucagon, which causes the organs to give up that glucose and push it back into the blood, okay? Or cause glycogen, increased glycogen breakdown or glycolysis. Okay. The pancreatic duct is a portion that is associated with the abdominal or gastrointestinal. It's a gastrointestinal organ, which is producing things such as pancreatic amylase to help in the breakdown product primarily of large carbohydrates, but also release bicarbonate into the duodenum. Okay, so now we have a continuation of the duodenum is this structure up here, which is going to come in deep to this transverse colon, and this is the jejunum. And that's going to curve. You straighten it out, you can get a jejunum that's anywhere between about 14 and 16 feet in length, from the duodenum down to the ileum, which is going to come over here and interconnect with the ascending colon. And so ileum is also of great length. So you may have in the lower portion of the small intestine, jejunum and ileum, you may have a tube that from the duodenum to the ascending colon is somewhere between 20 and 25 feet long. Which is, not a bad thing. It's kind of like, we talked about the epididymis the other day. The epididymis is said to be about 20 feet long. Why does it have to be 20 feet long? Because sperm, when they're released from the testis into the epididymis, are very immature and they're basically useless. So they have to mature inside of this long journey they have to take to get to the vas deferens, so that they can be viable to fertilize an egg. Because their journey is kind of rough actually from that point on. okay, in regards to certain substances that are secreted in both in the vagina and in the uterine cervix. Okay, so the vascular supply to these organs comes basically arterially from the abdominal aorta. The celiac trunk supplies the stomach, supplies the liver, supplies the spleen. These are really relatively large arterial branches that come off of this trunk. The superior mesenteric, which is just below the celiac trunk, is giving off branches to the colon, the large intestine, and the small intestines. So middle colic, as it comes around, down to the right side, the right colic, down to the junction of the ileum and the colon, near the ileocecal junction, the ileocolic, and then a large branch that gives off several branches to the small intestine that are referred to as intestinals. Those are coming directly off of the excuse me, superior mesenteric artery. There's an artery we'll look at in here, we'll look at the schematic. There's an artery that comes off of the superior mesenteric and another vessel, the inferior mesenteric, which is actually coming off of a branch of the abdominal aorta as a direct branch below the kidneys, and gives off a left colic, which comes up to the junction of the transverse colon and the descending colon, and the sigmoidals, which is this S-shaped curve that on the left side the colon has to make to get around the ileum. And then the superior rectal, which is a straight branch that comes down into the upper portion as the rectum comes down from the area of the sigmoid colon. Also coming off of the abdominal aorta are vessels that supply organs that are in or associated or adjacent to the posterior abdominal wall. The largest of those organs are the kidneys. Okay, so renal vessels are direct arterial branches of the aorta. Also, there are adrenal vessels or suprarenal vessels that are small branches, actually off of, in many ways, off of the renal arteries. Then there are, at the end of the aorta, if you remember when we looked at this, there are two large arteries that go down to the lower extremity that help to form the vascular bed of the lower extremity, and these are called common iliac arteries. And an extension of the common iliac, which we talked about last week, this external iliac also gives off a branch that winds up coming through the abdominal wall and winding up deep to the rectus abdominis muscle to really supply the rectus abdominis muscle, called the inferior epigastric. Internal iliac goes down into the pelvic cavity as far as the pelvic floor and supplies blood to the pelvic diaphragm, or sometimes referred to as perineum, and some of the pelvic organs, even including the uterus, but also organs such as the urinary bladder and prostate gland in the male. And then the lumbar arteries go to structures in the back, okay? But they will come around a little bit in the abdominal wall, maybe as far as the midline. All right, so let's look at these branches in here. All right, so here's the abdominal aorta. It's come through the diaphragm. This first large branch here, that is the celiac trunk. Okay, the celiac trunk typically has three main branches. One, a long branch to the left that actually passes deep to the stomach and goes over to the spleen, and simply is called the splenic artery. It has branches that come off that go to the lesser curvature of the stomach, called the left gastric artery. And it has a branch that goes over to, in particular, the liver. This is called the common hepatic artery, okay? And this will give off arteries that go to the liver itself, called hepatic artery proper. But we will also see some branching to the walls of the stomach. okay? There's the branches that come off here from this. This is called the gastroduodenal artery, okay? And it will give off a right gastric to the lesser curvature. Then it will give off an artery called the gastro-epiploic around, remember, connected to the lesser curvature is the greater omentum. So under the borders of the greater omentum, this is the omental or epiploic attachment to the stomach. We will see this here. This is a right epiploic artery, and then coming off of the splenic is a left epiploic artery. Okay. So as the aorta continues, there, right below the celiac trunk is this vessel. This is the superior mesenteric vessel. It will pass deep to the stomach. Here's the pancreas that'll receive, and the duodenum that will receive some of these duodenal branches from the gastroduodenal and pancreaticoduodenal. And here is the superior mesenteric. And it will have a branch that goes to the underside of the transverse colon, which is called the middle colic over here. It will have a branch that goes over to the ascending colon over here, called the right colic. And it will have a branch that comes down to the ileocecal junction, called the ileocolic. And these primarily are going to the right large intestinal tubes in the organism. Coming off of the superior mesenteric artery, here will be many, many arteries that are referred to as intestinals. And they form arterial loops that have an interrelationship to the walls of the small intestine, jejunum, ileum. Okay, so we don't see them here. We don't see them in this illustration. We just see where they've been cut. Here is the inferior mesenteric artery. It will have a superior branch here that comes up to this left colic flexure, and this is the left colic, okay? And then down in here, we have these that are taking care of this S-shaped portion, referred to as the sigmoidal arteries, and then this area here coming down to the top of the rectum called the superior rectal, okay? We'll actually see some of these as well. Okay, focusing in on the stomach, we see these celiac vessels, okay? We see these celiac vessels. Now, I showed you before, when we were talking about some of the sympathetic nervous system, that even though the sympathetic nervous system, preganglionic neurons are said to go from anywhere, some people say C8, but T1 down to L3, okay? There are other ganglia other than the sympathetic trunk, but the sympathetic trunk extends higher and lower than where the preganglionic neurons are, but it runs parallel to the spinal cord, to the vertebral column. Hence its name, a paravertebral chain of ganglia. Around the celiac trunk and around the superior mesenteric are also ganglia that sit on the outside or the front of the aorta. And these are referred to as being sympathetic ganglia, referred to as the celiac plexus of ganglia and the superior mesenteric plexus. And they take a position in front of the aorta, which is in front of the vertebral column. So they're called prevertebral. Okay? And we've got to distribute these postganglionic fibers a great distance through these tubular organs to follow these vessels that are supplying these organs. So, and remember, the difficult thing why you don't see these is that they're non-myelinated neuron processes. So you don't see postganglionic neurons of the autonomic nervous system. You do see preganglionic neurons because they are all myelinated. So here we see that kind of a blow-up of that celiac trunk with splenic, left gastric, common hepatic. Now, if we look at the small intestinal distribution, we can see some of these structures here, okay? Now, transverse colon has kind of been cut out of the way, so you see the branching of the superior mesenteric, the middle, the right colic, and the ileocolic. And here are the intestinals going over here. All of this connective tissue that is holding on to the intestinals here, that's the dorsal mesentery. That is protecting these vessels as they, and the arteries in particular, as they come forward into the small intestinal tube. Okay. So this back here is the dorsal mesentery. These are intestinal vessels coming off the superior mesentery to the jejunum and to the ileum. And here's the inferior mesenteric coming over here to the sigmoid colon. These are sigmoidals, to the left portion of the colon, the left colic flexure. So this is the left colic. And then we see some of the arteries coming to the right. Here's the middle colic. Now, if you notice with the middle, with the inferior mesenteric, we see this left colic coming up, and then it seems to continue around the border of the transverse colon, okay? So this is actually a arterial anastomosis, a junction of arteries coming from two primary vessels. These coming from superior mesenteric, this coming from inferior mesenteric. And they run along the inner margin of the colon. So they are called marginal arteries. And they were described by an anatomist named Drummond. So this is the marginal artery of Drummond that's interconnecting inferior mesenteric and superior mesenteric. So this is the marginal artery of Drummond. It's important to have collateral circulation in the body. That really in many ways can save our lives or save our organs, because blood flow can come from more than one direction if there's some type of partial blockage or complete blockage of the vessel. Okay? So, I'll draw this. This is inferior mesenteric. Here are your common iliacs. All right, so let's go from the arteries and let's look at venous channels, because this is where things are really kind of diverse within the confines of the abdominal cavity for very succinct reasons. Okay, and that the succinct reasons are: what is the organ doing in relationship to metabolism? So remember, veins do not have branches. Okay, they have tributaries. Small veins drain into large veins, drain into larger veins, drain into the vena cava. Okay. So what we are going to see is the tributaries coming into the inferior vena cava. We will have rectal vessels, the inferior middle rectal vessel, that are coming from the middle and inferior aspect of the rectum as it gets close to the diaphragm, the pelvic floor, and coming in. And then we'll have, these will join the internal iliac veins. The internal iliac veins will join the external iliac veins. And then as we go up, the renal vein, so all of these are going to eventually drain into the vena cava. The renal vein is going to, in particular on its left side, the renal vein receives the left gonadal vein. the vein that is draining either the ovaries on the left side or the testis on the left side, which is kind of an interesting formation, but is usually there all the time. On the right side, it drains directly into the vena cava. But on the left side, the left gonadal vein drains into the renal vein. And so these then drain into the vena cava, the renal veins. Then supravenal renal veins can either drain into renal veins, or they can drain directly into the vena cava. Also, the right gonadal vein will drain into the vena cava. And then also along the vertebral column, all of these lumbar veins will drain into the vena cava, and then eventually the liver will drain into the vena cava. The liver is the last organ in the abdominal cavity to drain into the inferior vena cava. All right, so this is tributaries of the vena cava. So this is called the caval system of veins. The inferior venal caval system of veins. These are veins that directly drain into the inferior vena cava. Then we have a system that's referred to as the portal system of veins. Now what's different? Well, the portal system of veins are venous channels that come from the abdominal intestinal organs, stomach, spleen, small intestine, large intestine, that not just drain out anywhere or into the vena cava, they drain first to the liver. They drain first to the liver. A portal system is a system where a vessel goes to take blood from one organ to another. There's another portal system that we'll talk about, or Tim might talk about in neuro, and that's the portal system associated with the hypothalamus and the pituitary. Okay. So this system of veins, before their drainage gets into the vena cava, first goes to the liver. The liver is this large metabolic organ that's doing all this work to try and, break down or package metabolic agents that we need or need to store. But at the same time, it is the primary organ which protects us. It is a kind of a detox organ. Sometimes it works well, but sometimes the problem is that if any of these organs become compromised with a disease like cancer, the liver is probably always going to be compromised. Another thing which goes back to kind of urban legend, I like all urban legends, okay? Chronic alcohol abuse has a drastic effect on livers because you've got these short-chain carbohydrates really going through the liver at a high rate, and the liver's got to try and do something with it. Okay? Kind of try and package them, and prevent any damage associated with it. Well, there is an agent called antabuse that years ago, in trying to control chronic alcohol abuse, physicians thought that they would give these patients antabuse. Well, what's the big deal with antabuse? Antabuse takes short-chain carbohydrates like alcohol and it turns it into formaldehyde. Isn't that a great thing to run through your liver? Okay? It's bad enough having to breathe it, right? But they gave the patients antabuse. And what this would cause is liver pain. Would cause liver pain. So they thought if they gave the patient this medication, that they would stop drinking because they were now always in pain. But, people are sharper than we give them credit for. They said, okay, before this, my liver wasn't hurting. The physician prescribed this medication, and now all of a sudden, every time I have a drink, the area of my liver is painful. So what do you think they did? Stop taking the antabuse. Okay? We're not that smart. clinicians are not that smart sometimes, okay? It's like, what did you think? What were you thinking? You know, that the patient would just enjoy being stimulated painfully and say, oh, I'm gonna stop drinking. The same thing as stop smoking, you know? So this antabuse was a agent that was given early on, probably in the late 40s, early 50s, to try and discourage people from taking in alcohol, from drinking. Okay. So it's a lot of kind of interesting things, both from an anatomy and a physiological perspective, both in dentistry and medicine. Okay, so these vessels, there are vessels that are coming from the lower portion of the body, associated with the inferior mesenteric arterial system, but they're inferior mesenteric veins. They drain not directly back to the liver, but they drain typically into the splenic vein, which is coming from the spleen and going to the liver. Okay? Then the superior mesenteric veins, which are draining opposite the path of the arterial flow, both the ileocolic vein, the right colic vein, the middle colic vein, the intestinal veins, they are draining back into the superior mesenteric vein proper, including sometimes this umbilical relationship. When we shut down the umbilical vein by cutting the cord, we then reduce blood flow from the placenta to the organism. However, there is a tissue vein in there called the paraumbilical vein, which actually has a relationship to not only the liver, but to the abdominal wall through these superficial veins. Okay? So all of these venous channels, the superior mesenteric and the splenic, join together to form a common vein which goes into the liver, which is called the portal vein. And it'll split into the different lobes and become hepatic portal veins. And then whatever happens in the liver will return into circulation into the inferior vena cava by hepatic veins. Okay? By hepatic veins. Now there's an interesting thing that happens with this paraumbilical vein. In liver disease or coronary disease that causes heart failure, what typically happens is you start to see a backup of blood flow either from the heart or from the liver, so you can get engorgement of blood in these organs, engorgement of venous blood in these organs. Also, you can get engorgement of blood in this tiny little paraumbilical vein that winds up sending the blood to this area around your umbilicus, and it looks like a head of snakes. Who is the mythologic entity who had the head of snakes? Medusa. So they call this type of a situation a caput Medusa presentation, where these veins become engorged and bulge out of the anterior abdominal wall. They can be due to coronary insufficiency. They can be due to liver disease, okay, that leads to this type of entity. So when you're a physician, you know, you're typically looking at these things on a regular basis. I'm not really sure these days what physicians look at it all, okay? Unless there's something that you come in and you seem to deem that this is serious, painful, some kind of thing is going on, you know. Otherwise, they'll send you for an ultrasound these days, or a little bit in the recent past, they'll have you have an MRI or a CAT scan, okay? So, very seldom sometimes do they actually have you disrobe, you know, for a physical, to look at the surface skin to see if these things are present. I think that's kind of dangerous, to be honest with you. Okay, the days of the old physician who actually looked at everything and made decisions based upon what they saw is kind of past. We now allow the electronics to do it for us. I say to individuals, including all of you that have a cell phone or a computer or anything like that, what happens when the power goes out? What do you got? I've actually thought about this, and I'm going to buy a large solar panel to connect to my iPhone and my iPad, so I can't lose power. Okay? In houses these days, you can put in a generator, usually powered by actually natural gas to do this. Okay? My son lives in New Jersey, and the house they bought in New Jersey, really not thinking about it, had a gas-powered generator. When Hurricane Sandy came, their whole neighborhood was shut down. There was no power anywhere from them down to the shore or further out in western New Jersey. They were actually a site for their neighbors to power up their electronic devices. Okay? They could have actually made a lot of money, but they were really more neighborly. All right, so here are the two venous systems, side by side. Here's the cable system. All of these organs down below, organs in the abdominal, posterior abdominal wall. Behind, you actually see it's dotted, behind the descending colon and ascending colon. The kidneys here, the liver eventually draining into the inferior vena cava, the IVC. Okay? That's the cable system of veins. Okay? What do we have above that? Where was blood draining? For example, we'll talk about this with the head. Where does blood drain into to get back to the heart? Okay, there's another vena cava. There's a superior vena cava. Okay. All right, here is the portal system. All of these veins are coming from the organ, eventually joining with this vein here. Here's the inferior mesenteric, here's the iliac, here is the right colic, here's the middle colic, here's the splenic, here's the inferior mesenteric joining the splenic, and here they are forming a portal vein and draining into hepatic portal veins inside the liver. So, not until they go into the liver will they drain into the inferior vena cava, because this is all of the processed metabolic entities that we're taking in through our gastrointestinal system. Okay? So they have to go to the liver first, if for no other reason for detox. Okay, here once again is this this view of the portal system. This time, we're not looking at these vessels draining into this vessel, the inferior vena cava. Here's the splenic vein, here's the inferior mesenteric vein. They are draining into this vein, going into the liver. That's the portal vein. Here's the splenic vein, here's a gastric vein coming in here. Here are the ileocolic, right colic, middle colic, draining into the superior mesenteric. Okay, so this is the portal vein associated with the superior mesenteric and inferior mesenteric. Okay, so taking away some of the entities, here we see the relationship of the aorta to the inferior vena cava. But at this point, we are still talking about the portal system of veins, at least here from superior mesenteric, has been cut. So all we see are the beginning of the venous drainage pathway. We see the inferior mesenteric draining into the splenic. We see the splenic and the top of the superior mesenteric draining into the portal system. Okay, so besides abdominal organs, this is an abdominopelvic cavity. And so there are organs that basically wind up below what we refer to as the pelvic brim. Here's the sacrum. This is the first sacral vertebrae. If we draw a line from the junction of the top of the first sacral vertebrae, this is the last lumbar vertebrae, L5, over to the top here of the pubis, that plane, everything below that plane now is not just in the abdominal pelvic cavity, it's specifically in the pelvic cavity. So here is a urinary bladder in male, here's the prostate. Here's the urethra coming through the male penis and the scrotal sac down in here. Here is this area of the rectum, okay, coming down here. So we see these structures that are more pelvic than not, okay? More pelvic than not, okay? So the uterus would be in the pelvic cavity, just above the female's urinary bladder back in here, okay? That's a problem, that's a problem during pregnancy, that here you have a organ associated with being the womb for this developing organism, and it lies behind the urinary bladder, and it lies in front of the rectum. So as the uterus is growing, the problem is that it is not allowing the urinary bladder to fill to its capacity because it's pushing forward, and it's not allowing substances to go from the sigmoid colon into the rectum quite well. So there's problems with in pregnant females. The problem that you have is, sometimes urinary urgency or the inability to store a lot of urine in your bladder, but also constipation. So not a, even though birth of a child may be a blessing, it comes with its own issues. Okay. All right. So then looking at some other organs which are back here in the posterior abdomen, we'll look at these again, and we talk first semester next year with structures in the posterior wall. So these are retroperitoneal organs. So along with organs like the urinary bladder and the uterus, the kidneys and the suprarenal glands are also behind the peritoneal cavity, adjacent to the aorta and the vena cava. So the kidneys and the adrenal glands are also retroperitoneal. Okay. Kidneys are quite well surrounded by not only peritoneum but fat, and that kind of makes sense because the kidneys are kind of out there in the open. Any of you do boxing, or have you ever done prize fighting in your lives? I mean, some of the things that your opponents try to do to you is they try to beat on your lateral posterior wall and cause pain in your kidneys, okay? Causing contusions of the kidney. So the kidneys are kind of wide open. They're below, they're typically below the rib cage, below the spleen, even on the left side. So they are retroperitoneal. The duodenum here and the head of the pancreas are retroperitoneal. Okay, some of these organs we see, I think we looked at this before. We looked at this once before. Okay, with the vasculature. Okay, so here's an aorta. Here is a celiac trunk. Here is the superior mesenteric trunk. Here is the right kidney, the left kidney. Here are the vessels going from the aorta, the right renal artery. Here's a left renal artery. The veins are typically adjacent to them, but they are cut in this aspect. So here is a left renal vein. Right renal vein is actually quite short here because the vena cava is more to the right, the aorta is more to the left. Here are these muscles back here. Okay. So once again, on the survival butcher's list, we have, if you're a vegetarian, you may have to really push yourself hard. But remember, the rectus abdominis was what? What kind of a meat cut is that in mammals, including humans? Okay. Remember, that's like flank steak, that's lemon broil, things like that. Okay. This muscle here This muscle here on each side, that is the psoas major muscle, okay? Psoas major muscle. What is the psoas major muscle as a cut of meat in mammals? That is beef tenderloin. That is filet mignon. That I saw, we were seeing, you know, if you're really hungry. But this, by the way, this week we do some periodic shopping at Costco. A strip of psoas muscle was going for $100, and that was the Costco price. Okay, so that's up there. Okay, so but you got to remember this. You know, you never know when you're going to need these. You never can know when you're going to need this information. All right, but coming alongside of the aorta here, actually pushed alongside. This is the lower portion of the sympathetic trunk. Here's the sacrum. Here is the first sacral vertebrae, and there's actually an extension of the sympathetic trunk on each side to join in the middle of the first sacral vertebrae and form a interconnection between the left and right sympathetic trunk, which is called the ganglion impar. Here is the ureter on the left side. The ureter on the right side is kind of pushed over to the right, over here. Here's the common iliac artery. Here on the left, here on the right. You see the external iliac on each side. What will the external iliac become? I think I told you. What vessel does the external iliac become? No, not saphenous. Saphenous is a vein. Okay. It becomes the femoral artery. Okay, the femoral artery. Here's the, excuse me, inferior vena cava, kind of covered up by the artery. Here it is cut free from the liver. Up here, the liver's been removed. You'll see this. Over here, here is a adrenal gland or suprarenal gland sitting on top of the kidney. Now, in all honesty, when you go in here, if you ever do a dissection for me, and you're doing this posterior abdominal wall, you won't see this because it's surrounded by a huge fat capsule, including the adrenal gland. So you really have to carefully dig away that perirenal fat, those perirenal membranes, to actually get a view like this, or in particular to see this suprarenal gland. But that sympathetic trunk is way down below the thoracic level at this point. Okay, I'm not going to worry about this too much because we'll talk about this in the course renal and blood. Next semester we'll talk about the internal aspect of the kidneys. So don't worry about this part of the PowerPoint but these posterior organ relationships to things like the aorta and to the inferior vena cava do understand those relationships and understand in particular with the venous tributaries how it differs in relationship to the caval system of venous drainage and the portal system of venous drainage. Okay? All right, I got it finished 3 minutes early, or 5 minutes early. How did that happen? What do you want to talk about?